it's very rare in the United States, but it's not so rare in Taiwan because of the founder effect. So can you talk about
Yes.
how you make the diagnosis in Taiwan?
Yes, I think for the diagnosis, clinical recognition should be the first step. But certainly in the past few years, we also developed a newborn screening for this condition. So I'm very happy that you mentioned Dr. Highland, because in my clinical trial for the 10 years, we sent every CSF samples to his lab. So that is the kind of the basis of the diagnosis. Yeah. But certainly clinical is still rare in Taiwan. So clinical recognition is very important. Actually, I think at a later time you will share your experience too. I think those children do have some very special clinical manifestation. I always tell other doctors that once you make one diagnosis, then it's not too difficult for you to identify the second patient. But in order to facilitate the diagnosis, so we can have a lot of suspicious cases, but how to confirm to that if you need a lumbar puncture CSF for every suspicious patient, that will be a lot of work. So over time, we developed some convenient, easy, quick assay. It's the 3O-methyl-DOPA assay. Because we are those biochemical newborn screening laboratory, so it's very easy that a few years ago we developed an assay, it's a tandemized assay, specifically for this 3O-methyl-DOPA compound. And this compound is very specific. It's only like two disease. It's AADC, the other is another one, it's POPN, that will cause neonatal seizure. There will be a third condition that you take levodopa. Yeah. So just recently, we found that actually in newborn screening, it's quite easy. I don't know if you know the newborn screen very well, because we do acylcarnitine for every child all over the world, almost over the world. And the recent method for acylcarnitine profile, we call this non-derivative assay. So we just elute the spores in buffer, and then we try to see everything as many as possible in that elute. Then we found that we can see this is 3O-methyl-DOPA in the elute. So now we routinely check the compound in DBS in every baby, but certainly we need a second tier assay put on an LC to confirm that. So I don't think it's so difficult now, but certainly molecular and the CSF is the method for confirmatory diagnosis. Thank you.
Okay. Well, you've come a long way adding it to newborn screening. We haven't gotten to that point. Let's ask Dr. O'Malley.
Yes, thank you. I think that this is one of those disorders that is so rare, but yet you don't want to miss it. And I think of all of the different diagnoses that we consider sort of the CP mimickers, and AADC can certainly fall into that category. And the presentation of these children in infancy isn't necessarily all that specific. So it makes sense, as Dr. Anselm was mentioning, that a large number of cases are probably as of yet undiagnosed. So when I think of this disorder, I try to think of this on my differential for any infant who has hypotonia of undetermined etiology, for a baby who maybe was a full-term baby with a normal birth history, no clear evidence of birth injury, but is profoundly hypotonic and failing to meet developmental milestones, AADC deficiency, amongst other disorders, is on my list of things to consider. And as Dr. Marks mentioned, I think for many of us in movement disorders and in child neurology, sometimes you get a patient sent to you with a chief complaint of spasticity, and then you have the chance to examine the patient and get the history, and you say, this kid doesn't have any spasticity at all. Instead, they have dystonia, or maybe they have a mixed movement disorder. And so I think when you're in the position to meet those children, we really have to be on the ball and think about reevaluating the diagnosis. Is a diagnosis of cerebral palsy really the most accurate? Is that as finely tuned as we can get for a diagnosis for these children, or could there be something else? And I think Dr. Ansam also mentioned some of the hallmark features like oculogyric crisis, or excuse me, oculogyric crises can start to give you a clue. But again, it doesn't necessarily mean it's AADC deficiency. So I think in my experience, as I've learned more and more about this disorder, I'm testing for it more frequently with a fairly low hit rate. But I think it's an exciting time right now because we have the ability to test for this. We have the ability to learn more about it and start identifying additional patients. And as we all know, there are really exciting treatments on the horizon for these children. So while historically we've been limited by just symptomatic treatment using medications to control the movement disorder features or other neurologic problems associated with the disorder, I think really looking forward, thinking about some of the treatments that we have on the horizon are potentially really big game changers for these kids. So it's a really exciting time to.
That's right. Absolutely. So Dr. Marks, can you tell us about your approach to the CP mimic? A child who really has no etiology, they present with some movement disorder. What are the red flags that might make you think of a neurometabolic disorder, how you approach these children, and any other comments you want to make about how you intervene?
Sure. So I, like Dr. O'Malley, I have a very low threshold for testing. Even in children sometimes with a typical history for CP, the preemies, if their picture's not quite typical, we have found now a number of kids with disorders that mimicked their CP, and it really wasn't their prematurity that was giving us all the difficulty. I think that's especially true when you're finding much more dystonia on your exam than you're expecting from the typical preterm infant. Surely with AADC, I think that the things that really trigger the thoughts of AADC are the children who have dysautonomia at an early age. Dysautonomia is a relatively common problem even in the CP population, but this early dysautonomia in a child who's hypotonic, you know, you may or may not see the oculogyric crises, and most of the time they're mistaken for seizures when you encounter them anyway. And so it may not be the movement people that get a hold of them first, it may actually be the epilepsy doctors that are seeing them. Usually what happens is they'll end up getting a video EG and they're not seizures, and then they call you and say, hey, there's having these eye movements, these are not seizures. What's going on here? The problem is that even in the children who look like, and I've seen now a few of these who look like they really ought to be pretty classic AADC, they're hypotonic, they're dystonic, they have oculogyric crises, they have early infantile spasms, they have bad seizures, and their neurotransmitters are definitely abnormal. But then you look at their brain and the basal ganglia are all beat up, and there's no real history to go along with it. But that really complicates the picture. Because you really shouldn't have the anatomic abnormalities in AADC, at least in the basal ganglia. This is a biochemical problem, not an anatomic problem. But I think if you keep those things in mind, and I think using the testing like the CP mimic, or the CP spectrum disorders panel that's out there now, we're finding lots of things, not as much AADC as perhaps we would think we would find. I mean, I think I picked up one carrier, again, anytime you see the oculogyric crises, you have to think somewhere in at least the neurotransmitter pathway, whether that's in tyrosine hydroxylase or anything down below that. then you have to think of it. It's not obviously common in straightforward DRD or dope responsive dystonia, but any of the further down processes from tyrosine hydroxylase on, you really need to keep those in mind. But even with all of that, there are mimickers. We've had one that multiple centers thought had tyrosine hydroxylase deficiency and had all the classic biochemical findings go along with it, and didn't, had something completely unrelated. So, you know, even when you think you have it, you still may not have it. So having the availability of doing the enzymatic assays is actually very helpful to sort that out.
Very interesting panel you mentioned, CP mimic panel. I'm sure you're talking about a gene panel. Can you tell us about some of the diagnoses that you have uncovered using that panel that you hadn't suspected?
Sure. Well, and some that perhaps we did suspect, but I've had a teenager sent to me with a movement disorder that had Rett syndrome. We picked up several kids with Angelman's. That may be one of the more common things that we pick up. We picked up actually, we picked up 2 or 3 kids with Rett along with the Angelman's kids. We picked up there are a multitude of these rarer genetic disorders that you can get to, but this panel has made it so fast that I think in some ways the genetic panels are actually changing the paradigm. And Dr. Wu talked about, and particularly in Taiwan, it's probably true because you have enough of this that you can look at the symptoms and think this is what it probably is. But with a low threshold for testing, sometimes you get the testing and your paradigm is, okay, well, I have these genetic abnormalities. Does that actually fit what I'm seeing in the child? So it has kind of reversed our thinking on how we're approaching some of this.
Very interesting. Thank you.